Dr. Jo Wray is a senior research fellow and health psychologist at the Great Ormond Street Hospital, and I'm going to turn it over to her.
Thanks, Diana. Right, let me just see if I can share my screen. Can you, oh, hang on a minute. Can you see that, or what?
Yep.
Oh, is that in, proper way of looking at it, is it? Okay, so, well, thanks, Diana, for inviting me to talk today. And just to give you a little bit of background, as Diana said, I'm a health psychologist at Great Ormond Street, and I work in the Heart and Lung Directorate. And then I'm also a researcher in ORCID, which is the Centre for Outcomes and Experience Research in Children's Health, Illness and Disability, which is also at Great Ormond Street. And then currently I have a role that's much more based on research and thinking about patient experience, patient-reported outcomes, and how we evaluate those experiences and outcomes. And then prior to that, I had some 20 plus years of working clinically with children with heart disease and their families. And I've slightly tweaked the talk title, so it's now focused just on congenital heart disease rather than acquired heart disease as well, because I realised there was too much to say. So just to give you an overview of what I'm going to talk about, so just to think about why congenital heart disease, and that's really from my perspective in terms of why I'm interested in it. A little bit about congenital heart disease for those of you who may be unfamiliar with it, thinking about invisibility along the life trajectory, and then what can we do about it and how thinking in a different way can help. So why congenital heart disease? So I guess this is really about where I started. So when I left university and was hunting around for a job, I got a job as a research assistant on a study that was being conducted at Westminster Children's Hospital. So it was a long time ago because the hospital doesn't exist now. And my role was to evaluate the control group in this study, the focus of which was children undergoing bone marrow transplantation. So that was children who had cancer and inborn errors of metabolism and various anemias and that kind of thing. And the control group were very much seen as sort of, they were just there for comparison, really. There wasn't a lot of interest in them, but they were a group of children with congenital heart disease. So I started off by knowing nothing about congenital heart disease, finding out about them from the families. And what became apparent was there was a huge amount to know about this group and listening to their stories. And I became very interested in that, and then realised that when I started looking in the literature, they were largely ignored in terms of psychosocial research. And people seemed very unaware of what the impact of congenital heart disease was. And then when I'd finished that project, I went to Harefield and I set up a clinical and a research service for the paediatric transplant programme there, and was also working with children who didn't have transplants but had heart disease. And again, listened to many more family stories, hundreds and hundreds of them over the years. And I've basically stayed in that field the whole time. And I think another reason why I was particularly interested was the fact that it's a very complex group of diseases. And if you think about the symbolism of the heart and how that might impact on their experiences, but so much of this is invisible, which is obviously the relevance of talking to you about it today. So just for those of you who aren't necessarily familiar with congenital heart disease, so it's the most common congenital defect and it affects 1% of all live births. So every week in the UK, 90 babies are born, and frequently the cause is unknown. And unlike other diseases, the spectrum ranges from very minor, so maybe a very small hole that might spontaneously close, to extremely complex. And for pretty much all of the patients, there is a need for lifelong follow-up. And in common with many other diseases, the advances in medicine and surgery mean that survival rates are now much better, and more than 90% will now be expected to survive to adulthood. So it's more common than things like cancer in children, but there's a lot less awareness and understanding of it. And frequently, the defect itself remains invisible and all of the associated impacts.
Jo, there's a lot of background noise. Is there something in the background that's
no, me sitting in my office on my own. What do you want me to do? Is it, can you not hear me? If I sit closer, can you hear better? Shall I continue? Okay. I think that's probably just the connection. And probably the gosh internet or something, I should think, because I'm at work.
Yeah. Well, there may not be anything we can do about it.
No, I'll just sit and hopefully, well, maybe it'll fade in and out, I don't know. Okay, so just, I mean, I'm not going to talk about the global perspective, but I just thought it was important just to give you a little bit of insight into it. So 1.35 million children are born every year with congenital heart disease. And I think unlike other diseases where perhaps they're making inroads into treatments, but also prevention, disease rates are very stable in congenital heart disease across the world, which means that the burden is greatest on those low-income countries with the highest fertility rates. And although across time we've seen a decrease in mortality in children's illnesses, mortality and morbidity have, due to congenital heart disease, have consistently increased in lower and middle income countries over the last 20 years. And I think the sort of fairly shocking statistic is that 90% of the children born live in places where they have inadequate access to diagnostics or care. So this is another really invisible sort of element of it. And you can see from those two things that are shown on the slide, you know, they call it a voice for the invisible child. So this is part of the global health agenda. And then that map just shows you areas where they don't have access to care. So you can see all of Africa and most of Asia. So just kind of returning to sort of more the impact of congenital heart disease in the developed world and thinking about early research. So back in the day, people were very much focused on the surgical and medical aspects of congenital heart disease, and it was all about survival. And people identified the major events, so the things that were very visible: strokes, seizures, significant cognitive impairment, which fortunately don't happen very often, and they have a very high impact. And from a psychological point of view, research tended to focus on sort of the harder data, so things like IQ. And aspects such as emotional impact, the psychological impact, was pretty much ignored. Since that time, there's now been recognition that there's a more sort of subtle picture, and this has a high prevalence and a low impact. And we know that actually these children, as a group, have worse executive functioning. They have issues with their motor function, language development, mood disorders, academic difficulties, and all the other things that you can see listed on that slide. And then the other thing that people are increasingly aware of is the impact on families and parents, and also siblings, although I think they are often the most invisible. So thinking, this was some work that came out of the States from a cardiologist there, really trying to come up with this sort of developmental signature for children. And not surprisingly, when we think about development, the more severe the congenital cardiac defect, the more likely a child is to have disabilities. So the children with severe and complex congenital heart disease, or those with syndromes, have higher rates of severe disability, which do tend to get identified. But I think that the children that I think are relevant for today's talk are those who have mild disabilities, and particularly those who have mild congenital heart disease or moderate congenital heart disease with those mild disabilities, because they just don't get identified. So thinking a little bit about the across the life trajectory. So one of the issues is that although increasingly children are being diagnosed antenatally, there are a proportion of children who are not diagnosed until days or weeks postnatally. And so those children who are late diagnosis, there is the likelihood or potential for mortality, morbidity and disability that would be avoided if those children had been diagnosed. For those children who are diagnosed and then quite often have surgery in those first few days, when those parents take their children home, they can often become isolated from the normal community support because of the risk of infection. Parents are often very anxious about having this baby who's undergone surgery, the impact of that hospitalization, and feeding problems are very common. And then the impact of all of that is that you get high rates of maternal depression and an impact on not only the baby, but the parents and the other children as well. And we did some research, an NIHR-funded study that was led by Kate Brown at Great Ormond Street. And one of the things we wanted to explore with families was what their experiences were when they took their child home after surgery in that sort of early infant period. And what they talked to us about was this whole thing about isolation. They felt isolated from the well baby community, and they described all of the things that made them feel isolated and invisible. So the things that they were having to do in terms of, as I said before, some of the feeding difficulties, their anxieties about infection, but also the way that they felt they weren't part of that community. So they couldn't take their children to those well baby clinics. And so that became an increasing picture of isolation and then increasing rates of maternal depression and anxiety. So then thinking about preschoolers, and another piece of work that we did, we looked at morbidities following cardiac surgery. And we did some work with families and professionals, and we found that the thing that they were most worried about, their highest priority, was about neurodevelopmental problems. And one of the issues that we have in the UK is that there's no routine monitoring of development for children with congenital heart disease. And quite often they describe these problems being detected late, and that means that the children can't be referred and then intervention gets delayed. And part of our study involved 971 preschool-age children in the UK, and we found that a proportion of those who were identified as having developmental delay on psychometric testing, they were not under any follow-up at all. So they were completely invisible to that sort of wider community of paediatricians and speech and language therapists. Then the consequence of that is that they get to school, and then you find that actually some of these more subtle problems become more of an issue, and quite often teachers don't see it as related to the congenital heart disease, so they might then ascribe it to something else. We also know that quite a few of these children have undiagnosed autism and ADHD, and then associated with that, and there's other sort of hidden mental health issues. For children who've had surgery, they might have concerns about scarring, and they're trying to keep their scars hidden. And another issue that sometimes happens is that they have less physical stamina than other children their age. But again, people don't necessarily associate that with the congenital heart disease. And so there's this big hidden burden of disease, and that then has an impact on how well they perform at school, their participation, and how well they integrate, and then aspects such as their self-esteem and their self-confidence. This is just some data from a study that was carried out a long time ago, but it just shows that in a group of children who had surgery as neonates for transposition, more than half of them had problems in one or more areas. So this is not something that's of no consequence, but in the absence of formal testing, it just often goes undetected. And then that sort of carries through into the fact that if people don't know that these children have these problems, they're not necessarily putting the right interventions in place. And this was some data from the States, and they looked at survivors of complex congenital heart disease, and they found that, okay, half of them were doing okay and they didn't need any help. And then there was almost 40% of them where they identified that they had additional needs and they got the help that they required. But 11% of them, and when you think about the huge numbers of children that there are with congenital heart disease, so 11% of those children were performing at a below average level and were not receiving any help at all. And then thinking about some of the sort of more psychological and psychosocial issues. So another piece of work that we did was to develop a quality of life measure for children with congenital heart disease. And one of the things that became very apparent when we did some of the focus group work was how important the children and the parents found it that we actually spoke to them about their fear that they might die. So that was a question that was then introduced into our questionnaire. And one of the big barriers that we had was that the cardiologists and other health professionals did not want us to ask that question. And it was this unspoken fear, and a lot of the professionals felt that we shouldn't be approaching it, and they were worried that if we asked children and families about it, it would make them think about it. And actually, what we found was that the people who hadn't thought about it either disagreed, thought it was a strange question, but it didn't upset them. But actually, there were significant numbers of children and parents where their child was afraid of dying, or the parents thought the child was afraid of dying. And actually, when we did the kind of follow-up to that, what they really appreciated was the fact that somebody was asking them that question, and they wanted to talk about those fears, and they didn't want them to remain hidden. And then just want to give you talk about one particular patient. So this was a transplant patient. We know that transplant patients have increased risk for all the things that you can see listed on that slide. But one of the things that we often don't really sort of discuss with them in any detail is how their identity is sort of linked to their heart, I guess. And one particular girl, and I think she illustrates the challenges of this really well. So this was a girl who had congenital heart disease, and she was transplanted as a young teenager, and her parents had been told that she wouldn't live beyond the first week, told to take her home and she would just die. But she didn't die, and she was listed for transplant. And up until the point of transplant, she had a very clear sense of her own identity. And although she was very small and she was quite blue, she was going to normal school, and she knew who she was, and everybody else knew how to relate to her. And then she had her transplant, and she did really well from a sort of physical point of view and a medical point of view, but actually psychologically she got deteriorated a lot. She ended up at a school for children with special educational needs. She ended up being kicked out of the guides, and everything was just sort of falling off a cliff. And it was trying to understand what was happening to her. And when we actually started talking about it, a lot of it was this, as she described it, this invisible grief for the heart that she had, her native heart. And she felt that heart had been forgotten, and we had sort of metaphorically chucked it in the bin. And to her, all of her identity and who she was tied up with that heart. And so what she needed to do was go through a period of grieving for that heart so that she could then accept her donor heart. And then I think the other thing just to mention in terms of transplant is often the donor hearts are invisible as well. And then just thinking about transition, so our young people will transition to adult services. We know that it's really important that they do, but we also know that we lose a proportion of them at follow-up, and they become invisible to the medical teams. Some patients perceive themselves to be invisible, and there's a quote here, so they felt that they were abandoned by the medical team. Others see their invisibility as beneficial, and again, you can see this quote, so this patient felt that it was actually very useful that they hadn't had any follow-up because they didn't see themselves as in need of any care. And other people are just unaware and never realised that follow-up was important. And then finally, just thinking about adults, and again, this population can often struggle in adulthood in terms of thinking about careers and employment. They're more likely to be unemployed and less likely to receive career advice. We know that that can be linked to increased rates of depression. And again, this is another sort of part of the population who are invisible to wider society. So I think across the age spectrum, there's invisibility all along the way. So what can we do about it? I just wanted to give you a few examples of things that we've done, and obviously there are many, many more examples, but just some of the ways we've tried to address some of that lack of visibility and awareness, I guess. So thinking back to what we were saying about neurodevelopmental difficulties not being identified. And in the UK, as I'm sure you all know, for the first sort of 2.5 years of a child's life, any child's life, they get followed up by their health visitors. And they dish out an ages and stages questionnaire. But one of the difficulties is that they're not really sort of sensitive enough to pick up some of the problems that the children with congenital heart disease might have. And neurodevelopmental concerns, as I said before, are often missed in those early years. And that means that those interventions don't happen when they could do. For the children who have complex and very visible problems, they can then fit into a sort of scheme of identification and follow-up. But our concern was about the fact that these children were being missed early on, and we couldn't just say, well, it was in the complex ones only, it was across the spectrum. So we decided that we needed to try and develop some kind of tool, some kind of screening tool that could be used by health professionals in the specialist centre. It would be quick, it would be valid, it would be useful, importantly, acceptable and accessible, and cover the important areas of development that are relevant for a child with congenital heart disease. And what we came up with was, this was part of the grant that we got from NIHR, so we developed this tool, and you can see this is an example of what we would fill in for a child aged 15 months to nearly 3 years. And it's very simple. So it's a traffic light system. It's about surveillance, and it's about identifying children who are potentially at risk. And then we continue that piece of work and work with professionals to understand, actually, if we did identify a child who perhaps scored in the red or the amber, what should we do about it, so that we could come up with some kind of consensus for following up these children where we felt there might be a problem. And the thing that we felt was important with this is potentially it could be used with all children with congenital heart disease, because it is very quick. So even that child who maybe has a small hole in the heart that maybe people wouldn't expect to cause any problems, perhaps there is a problem, and this way we would be able to pick it up. Another thing that we can do in terms of trying to understand what's going on is monitoring. And the International Consortium for Health Outcomes have come up with standard sets of measures. So this is about recognising that we need better monitoring for children when they're not in hospital, covering all the domains that you can see listed on that slide. And for us, one of the things that we were very pleased about was that our quality of life measure was recommended as the measure that should be included. But other illness groups have used other things. So the other example on this slide is that, again, it's a daily tool that children and families can complete at home. And it's about linking in with their centres and making people aware of what's going on in their lives, what's working, what's not working, things that are worrying them. So particularly thinking about sort of mental health things. Another approach that I think is important to try and increase visibility is taking a systemic approach to how we think about these children. So they obviously don't exist in isolation, they exist as parts of families and then in wider communities. And we have used this approach sometimes in some of our work with some of the children and families. So just to give you a quick example, so this was a girl who had neonatal repair of transposition, so she was extremely well, she wasn't on any medication, there were no obvious restrictions, and doctors and her parents felt that she had an excellent quality of life, so all seemingly fine. But actually, what they were clearly unaware of was that she wasn't fine at all, and when she was asked to think about her quality of life, she rated it as pretty poor, and she scored particularly badly on sort of the social, emotional, and school functioning. She felt that her physical quality of life was good, and she was also having some memory problems, were quite subtle, but were clearly having an impact on her. She had issues related to her scar. She felt different to everybody else, but she felt that nobody was aware of those struggles that she was having, and she didn't really know how to communicate about that. And she felt left out, and the result was that her self-esteem got worse and worse, and she started to fall behind academically. So the approach that we sort of tried to work through with her was to think about the different aspects of her life, from taking that systemic approach, and to think where we could try and get interventions in place that might address some of the difficulties that she'd identified. So whether it was about getting some additional help from school, whether we could think about things to help her in terms of her scar, that she, so that it could be concealed, but she would feel more able to then mix with her friends, go swimming, that kind of thing. One of the suggestions was that she might want to join a group of other young people with congenital heart disease. And perhaps one of the most important things that was identified was identifying a new hobby for her. So she started martial arts, and then she was able to do that with her sister and her cousins. So taking that systemic approach enabled us to kind of bring out those, make visible those invisible problems that she had, and kind of do something about them. Part of, I think, one of the things that we can do is to try and help families to normalise their experiences, and obviously support groups are well known to everybody. There are various sort of technology things that that people have tried, so creating virtual communities or experience journals, all with a view for helping people who are perhaps feeling very isolated and alone with their problems to share their stories. And I think they do have positive effects in terms of decreasing those feelings of isolation, increasing the feelings of being like other people, and their sense of being part of a community and having a bigger social network. And then one of the things that I'm particularly keen on are things like the transplant games. So for many, many years, I've been involved in taking children who've had transplants to the transplant games. There are British ones, and then also some of our children have gone to the World Transplant Games. And what we've found there is that it's had a hugely beneficial effect on self-esteem, their attitude to the transplant, and it's really helped them to realise that they're not alone, and it's reduced their feelings of isolation, and they've been able to kind of share and normalise those experiences. And I think the other really important thing about things like the transplant games is that it increases public awareness. And then another initiative that we started at Great Ormond Street was taking some of our young people to transplant camps. So we took them to the PGL camps, so they're there with other children from, I think they tend to go when they're in year 6 in this country, but so children who haven't got any health problems. And this idea, we take them away for 6-7 days and kind of getting them to confront some of those fears, some of those anxieties, to try and come out of their comfort zone a little bit, to show them that they can do some of these activities. And the other bit that we do is that some of the team go as well, so some of the doctors and some of the nurses. And what the young people see is that they also have fears. So certainly when I went and I had to go and climb to the top of the trapeze, and I was absolutely terrified. And the young people could all see that. So I think it helps them to feel that we all have these kind of invisible fears. One of the things I think is also important is that how we help children, we facilitate ways of them talking about their feelings and describing their health. And one of the challenges, I think, is particularly with younger children. And another grant that I was involved in was involved trying to develop a character that could sort of show these different health states. And what we did was we worked with children in a school to say, well, what should this character look like? What should it be called? And we had all sorts of issues around making it relevant to all sorts of different groups of children. And then we worked with an animator who, and hopefully this is going to work, who then animated a series of different health states. So, for example, one of them is about sleeping problems. Again, children might not say that they have any sleeping problems, but if I can get this to work, what this did was it showed these different states of sleeping problems as an animation. And actually what we found was that for younger children particularly, this worked really well in terms of them being able to talk about the problems that they were having. On to the next slide. And then another one, this one is representing pain, so the same idea. And again, pain, we all know that pain is often something that children don't talk about, or they don't know how to describe it. And again, this use of this animated character really helped children to talk about their pain and to visualize it a little bit more. And then finally, just want to talk about a few specific pieces of work that we've done at Great Ormond Street. So one of the things I think we feel that young people struggle with is how to talk about their heart disease. And part of that is because it's invisible. Nobody can see it, and they don't really know what it looks like or how to describe it. And as you'll be aware, increasingly people are using 3D models in all sorts of spheres of life really to make visible some of these things. And in the field of congenital heart disease, 3D models have been around for a while and have been primarily used for teaching purposes, surgeons to practice the surgery that they're going to do, that kind of thing. But what we wanted to do was to see whether it might work as a way of helping young people to talk about their heart problem and as a communication aid in those consultations. So we did a piece of work whereby we printed patient-specific models so that when the young person went into their consultation, the consultant could use the model as a way of opening up a conversation. And it helped to make visible this invisible defect, also made it real. And what we found was this wasn't for everybody. I think it's important to say that. So some people were quite anxious about them making this visible. But a lot of the young people really engaged with it. They wanted to see their own heart models, and we found that it increased their confidence. It definitely facilitated communication. And what they also saw was that it would be something that would be useful for them to try and explain to other people something about their condition. So we've got another project running at the moment where we've given young people the models to take home, and then what we're trying to do is to see, actually, do they use it when they want to talk to their friends? Does it help them in sort of making this real for other people as well as for them? As you can see, they do talk about this, visualizing what's going on. And then the final thing I want to talk about is a project that some of you may have heard of. It's one of my greatest privileges, I think, was to be able to work on this project called The Heart of the Matter. And it was a project that was run in conjunction with Sophie Layton as an artist and Giovanna Biglino, who is a bioengineer. And we got some money from the Wellcome Trust. And the idea was to think about how it was a public engagement award. So it was about increasing awareness and making the invisible visible. And the idea was to explore what the heart meant to patients, but also other people as well, and exploring that sort of medical and poetic aspect to the heart. And the stages of the project were we ran a series of workshops, all-day workshops with patients, and I'll show you a few examples of what we did, because these were creative workshops. And then from that, Sophie and some other artists made some beautiful art, which we then put together as an exhibition that was in 3 centres in the UK and had a lot of audience. And then we used that to sort of evaluate what the audience what their feedback was on the exhibition and how that helped to increase awareness. So just quickly, just to give you a little bit of insight into what the project involves, as I say, we ran a series of workshops. So for the patients with congenital heart disease, they came to 2 workshops. They ran for the whole day on Saturdays, and they did a series of creative exercises, as you can see listed on this slide. So they did some work thinking about the blind self-portrait drawing and sculpting. That was thinking about the differences between 2D and 3D images. And we got them to think about what that meant, what that felt like. They did some creative writing exercises and then some body mapping. And then at the end of the first day, we reflected on the experience that they'd been through, but also we showed them some 3D heart models, and we talked a little bit about that. And then on the second day, which tended to be a few weeks later, they did some other activities, so embossing and another creative writing exercise. And then we got them to look at some MRIs, so some 2D images of their own hearts, and we got them to kind of outline them and perhaps title them. And then we talked to them about how they would feel if we showed them their own heart and what their reflection was on that. So this is just some pictures of the 2D, the blind portrait, 2D blind portrait drawing, and then the 3D sculpting. And then this was some young people getting involved in the body mapping. So they lay on a piece of paper and drew around each other, and then they spent quite a few hours kind of thinking about the imagery that they developed through the creative writing exercises and putting that into their body maps. And then we put all of those on the wall, and then we talked about why they'd put into those body maps what they had. And then the second workshop, so they were embossing. So this is an example. So Sophie had kind of pre-printed these hearts, and then they put images into that. And then this is an example of a young person, this is their MRI, and then how they, what they wanted to do in terms of colour. And I think a really interesting title, so they saw their heart as vibrant. And then this, these are a couple of patients who are holding their own models of their hearts. And after a while, we decided that what we would introduce was a question about what would they like to say to their heart. And I mean, I haven't done this exercise, but I guess for these patients who have lived with congenital heart disease for their whole life, so these were 2 adult patients, you can see that their hearts look very different as a result of the congenital heart defects. So, one of them has got lots of collateral vessels, as the heart's been battling away with things, very different to the other heart. But actually asking them what they would like to say to their heart really brought to the fore those kind of innermost feelings. And it was quite a challenging sort of exercise for them and also for us, really. Some of them got very angry, some of them got very upset, and a lot of sort of themes kind of arose. So this is just to give you an example of some of the sorts of things they talked about. So we had some transplant patients. So obviously the heart they were looking at was their transplanted heart, but they did talk about the loss of the heart that they'd had. Some of them were deteriorating, and I think holding a model of their heart in their hands made them sort of be able to express the feelings that they had for the life that they were no longer able to live. Some of them were angry that their heart was letting them down. We got a lot of sense of the battles, the fight, the resilience. And I'll show you in a little while one of the particular pieces of art that sort of reflected that. They talked about being grateful to their heart as well, but also quite high levels of anxiety. So all of these things came out, and I think this very kind of present way of holding the heart and thinking about it really helped them to express those feelings that perhaps they hadn't expressed before. What was very interesting with one of the patients in particular, so this was a patient who nobody was sure he would come to the first workshop. He hadn't gone anywhere. He pretty much wouldn't leave his home unless it was to go to the hospital. He certainly wouldn't go to the shops or wouldn't talk to anyone, wouldn't mix with anybody. And actually, when he came to the workshop, after the first workshop, he came back to the second workshop, and he was able to talk about the anger and all of those hidden issues. And I think he felt that it was a safe place to do that. He was with people who also had their own issues, who understood what congenital heart disease was about. But the most extraordinary thing about him was that when he then came back to view the exhibition, which happened a few months later, what he'd been able to do as a result of coming to the workshop and kind of expressing those feelings and making things more visible was that he'd then been able to book a holiday and he'd gone abroad, which was a huge step forward. So although these were not ever thought of in terms of a kind of from a therapy point of view, they had quite a sort of therapeutic benefit. And these were just we asked participants to sort of tell us at the beginning of the workshop how they were feeling and then how they felt at the end. And you can see that at the beginning, quite a lot of them felt very nervous and apprehensive. They weren't sure what to expect. But actually, they enjoyed the workshops, importantly. They found them fun, and also that ability to reflect. And there are some quotes here. And I think one of the interesting quotes for me was an adult patient. It took coming to the workshop for her to realise that her heart disease was something she was going to have for the whole of her life, even though she had known, she'd clearly been born with it. And again, that sort of speaks to the fact that these things are not talked about. Many families, they are invisible, and that can have quite a detrimental effect on the patients. And then just to give you a little bit of insight into some of the things some of the artworks that were created. So we held exhibitions in Newcastle for 5 weeks, and then in London and Bristol. And just quickly flick through these. So these were some of the artworks. And it was just a stunning exhibition. This was when I told you about the soldier, the kind of all that imagery around battles, and one of the pieces that was created was called Soldier Heart, and it was to take some of that imagery, and this was what they created was a hologram of a girl in kind of combat gear, and that was projected into a 3D transparent heart. And we actually wrote about that because it was such a strong sort of emotion that was coming through this fight. And we wrote a composite narrative, so we took elements of all of the stories to be able to just try and make people more aware of the battles and some of the imagery that they talked about. Similarly, one of the patients, one of the young people, actually, when he got his picture of his heart, he drew that little kind of cartoon character that you can see, and he called it My Core, and that got translated into a series of photographs. So a huge giant heart was made, and actually these were the images that people felt really resonated with their own stories. This burden of congenital heart disease, the fact that you can never put it down, you can't escape it. Everywhere you go, whether you're having fun, whether you're attending hospital, it's always with you. But at the same time, they wanted to convey the preciousness of it, the importance of it, and that's why it was made out of this red velvet. And this is, you can see it, this is interesting. So lots of people wanted to have their picture taken with it when they came to the exhibition. And then final piece I just wanted to quickly talk about. So one of the patients talked about his heart being like a Rubik's Cube that could never be fixed. And I can get this to work. So this was made into, and you can probably hear the clicking. And it was this sort of kinetic model, and it never quite squared up. And actually, interestingly, this patient's mother, she talked about the clicking being like the pacemaker that he had that she could hear sometimes. And then we got feedback from people who came to the exhibition. We got huge amounts of feedback, actually. And what we realized was it really helped people to be more aware of congenital heart disease, to be more aware of the impact, to think about what it meant for families. And it was in a way that was sort of accessible to people, and lots of really, really positive feedback. So we did a lot of evaluation, and actually over all of the various exhibition configurations, we also had a weekend where some pieces were shown at the V&A. And you can see from this, we got a lot of kind of, huge amounts of people seeing aspects of it, either online. We had 100,000 people who came through the exhibition, and then the feedback comments were very positive. So I think summarising, I think for patients with congenital heart disease, invisibility is a very real problem across the whole of the lifespan, and although we're getting better at dealing with it, there's still a long way to go. I've tried to kind of just identify a few approaches that we've taken to increasing that visibility, but I think also it's important to realise that actually not everybody wants it to be visible. So I haven't really talked about that, but we have to be mindful and respectful of what people's individual wishes are. But I think that the arts and the humanities offer a very exciting way of increasing visibility, because they enable greater access, and we can provide insight, context and understanding in a way that is something that people can appreciate, understand and relate to, I think. So thank you. And I've picked these images on purpose because I think, and I'm sure you've had probably lots of iceberg type things if you've been talking about visibility and invisibility, but what we see is the tip of the iceberg, not only as professionals, because obviously these families hopefully are not in hospital very much, but actually in the context of their lives, because so much is hidden. But then I think it's also important for us to realise that that what's presented to us is often that kind of serene coping sort of front, and actually things may be very different under the water. And then just these are the funders for the heart of the matter that I should also acknowledge. Thank you.
Thank you so much. That was brilliant, and I'm actually speechless because it was so amazing. Anyone can put questions in the chat, and feel free to put your hands up if you want to ask a question, but I'll kick it off. I like that you ended with a picture of an iceberg, because I literally wrote that down, because that's the analogy I use for invisible disabilities, is that you have what's on the surface, this is what you see, but underneath is what's actually going on. All the pain, the struggle, all the navigation of all these different issues. And so I thought that was really great that you did that. I thought it was really interesting that you were talking about the quality of life indicators and introducing those, because I think sometimes that sort of gets forgotten in terms of from the patient perspective. And and also the traffic lights assessment. And in terms of, one question I have is, in terms of the communication tools that were developed for children to communicate how they were feeling to, say, other children or to providers, how effective do you think those tools were? Like, how do you think the public was receptive to it?
Do you mean the animated characters? Is that what you mean?
Yeah.
Very receptive, and I think what it did was it gave particularly younger children, because they don't always find it easy to communicate some of those things. So we worked on constructs that already existed in other studies. So people have tried to kind of use an approach of getting children to kind of rate their health status, but actually haven't necessarily found a method that engages children particularly. So what this did was enable us to develop a method that children absolutely engage with. And then we tested it. So we said, well, would you prefer words? Would you prefer static images? And it was the animated characters which kind of got them interested in the first place, I guess. And then, although the aim was not then to have a conversation necessarily about it, because that tool has been developed more kind of just so we can measure those things, but actually it does enable you to have a conversation, because I think all of these communication tools, they might go in with one way of engaging the patient, but once you've engaged them, then you can kind of continue. And I think engagement is where we struggle sometimes, and often there isn't enough time to perhaps do it properly or in the way in which we might want to. So, yeah, I think these tools are all really helpful. And I guess in an ideal world, what you'd have is a kind of a toolkit that you pick from, because clearly not all children would be able to or want to use those kinds of approaches. A little bit like the heart models, that's not for everybody. We have to be mindful of that. But I think we need to have a range of things that enable us to help young people and families talk about those things that are kind of invisible to us as professionals.
Yeah, and I was also thinking about children in school, like to communicate to educators, because I think that's also a really huge gap and barrier for children that they struggle with.
I would agree. And actually, one of the things that was interesting about the heart of the matter was, because obviously it was, the public that came to the heart of the matter, and lots of children came. And then when we were in Newcastle, they actually had one of the classes did a school trip to come and see it. And actually what they all taught, a lot of those children wanted to talk about, their granny had something wrong with their heart. And it didn't matter that it's not congenital heart disease. It got them thinking, it got them aware that maybe they knew a younger person who had congenital heart disease. And quite a lot of people brought, so people who were from Newcastle, attended Newcastle Hospital, they wanted to bring their children and some of their children's friends to use it as a way of having some of those conversations. So I think all of these things have a really important part to play in opening up those channels of communication, increasing awareness.
Okay, yeah, I agree. Thank you. Does anyone else have any questions? Feel free to jump in.
Oh, so there's a question here about, a mentorship scheme. Not that I'm aware of quite in the way that I think you mean it. I guess maybe through some of the charities. So some of the charities, so for example, there's a charity called Little Hearts Matter, which covers the age span. So I guess there will be some connection in that way through some of those charity events. I guess charities and that kind of thing would be the most likely way. I'm not aware of any other kind of projects, but I think increasingly people want to know, well, what's my life going to be like as an adult? And actually, from a transplant perspective, when I was at Hereford, that was a question that I was always being asked when I was doing the assessment. Well, what's going to happen to my child when they're an adult? And actually, what we realise is that a lot of that work hasn't yet really been done and articulated in terms of following up children who are now adults with a transplant. So it is on my list of projects to try and get some funding from. I see Dr. Marks is on the call, so perhaps we could do it for kidneys as well. Because I think it's really important that we have that sort of lifespan view, because these children and people are living longer. We need to understand that.
I'm just going to read out the question so people know for the recording what we're talking about. It was, is there a project that connects adults with CHD with children with CHD, something like a mentorship scheme? So that's what we were just talking about. And I think that was a really interesting answer. And I think it's having, the lifespan view is really important. Does anyone else have any questions?
I think actually just to kind of add into that lifespan view, so there's another project that's going on which is looking more at adult outcomes of congenital heart disease, and we've run some online forums with some of the patient charities, and we've had people on the forums who've been in their 50s, 60s, 70s with congenital heart disease who, and you realise, because that's quite unusual, they really are invisible to society, and people, I have to say, I hadn't really thought about people of that age being alive with congenital heart disease. So again, I think it's about heightening that awareness and facilitating those conversations.
Absolutely. Have you ever used the tools like spoon theory to communicate with other people about awareness, about how CHD affects them?
So one of that's interesting. So one of the charities, Little Hearts Matter, the one I just mentioned, actually that's been something that they've been trying to use for their young people to help them communicate to people who haven't got congenital heart disease what their life is like, and in terms of energy and kind of how that works, and how many of their spoons they've used up. And that's been an effective communication tool. So I haven't used it personally, but I've been involved a little bit in the work that they've done, and it has been a very useful thing. So I think all those sorts of things, I guess it's another thing for the toolkit, really, what works for whom, giving people choices and options.
Yeah, definitely. Yeah, I mean, I that's what I use. That's why I was just asking, because I know it's commonly used. Anyone else have any questions? I was sort of wondering, what are the next steps in terms of your research? What are you going to do next?
So one of the things that I think from the heart of the matter work, one of the things that we realised was that we are not picking up on the cultural sensitivities. So, congenital heart disease, there's a higher incidence of complex congenital heart disease in, for example, the South Asian community because of all the first cousin marriages and that kind of thing. And they are some of the groups that don't access healthcare and are less visible to us as health professionals. So we had thought whether we might try and get funding to sort of do another run of the heart of the matter, but with different cultural groups that might enable us to connect with them in a different way, or for them to connect with each other and to raise awareness to them and their own communities. So that is one project that we're looking at. As I say, want to do something around following through on the sort of lifespan of the transplant patients, so following up patients in adulthood who were transplanted in as children, to really understand what their lives have been like. And I think that would be really important for informing families as they come along the way, so that they can, kind of know some of the things that they should be expecting in adulthood. So, and as I say, those are the questions that people want answered, and we need to be able to answer them for them.
Great, thank you. If anyone else doesn't have any questions, I'm happy to conclude this seminar. Thank you, Dr. Jo Wray, for presenting your amazing research and public engagement work. It's really brilliant to see such a wide range of work to try to make disabilities that are invisible visible. And I sincerely appreciate it. And I'm sure a lot of other people do as well. This is just a reminder, we also have another seminar tomorrow at the same time. at 1 p.m. With Professor Sarah Ryan. And that will be the last seminar of our series this month. And later in the summer, we'll actually be doing a spoon theory workshop. So look for an email for that. So thank you for coming and have a good rest of your day.